Okay, Dr. Anderson, go ahead and share and start.
Well, I'm going to switch gears. I assume, Diane, everybody can see my slides here.
Yes.
Yeah, so I'm an orthopedic surgeon. So although I might be a curmudgeon like the previous two speakers, I look at things a lot differently. And I'm going to really talk more about a programmatic change on how to apply what we think about fractures to the elective orthopedic patient. And it's really talking about bone health optimization. And it's really what you don't know will hurt you, as you can see in these types of postoperative fractures that occur. I have a number of financial disclosures, but none of them really are going to affect what I'm going to say here. Uh, the objectives are to encourage orthopedic surgeons, but particularly FLS programs or endocrinologists and other physicians who care for bone health to treat uh, the elective orthopedic surgery patient. And I'm going to cover three areas. Who needs further diagnostic testing, that is like DEXA examination, how to screen for this, and then how to provide a treatment if warranted. So we know what the consequences of osteoporosis, and we kind of think primarily it's fracture. Well, there's actually some evidence that it's associated with diseases such as osteoarthritis and scoliosis and kyphosis. I'm not going to talk about that, but I am going to talk about the linkage of osteoporosis with poor outcomes from elective orthopedic surgery, such as total hip and knee replacement, as well as what I do, which is spine surgery. So bone health optimization is the process to assess bone status, identify and correct metabolic deficits, and initiate treatment when appropriate for the skeletal structural deficits. The goal is to improve outcomes, reduce complications in a cost-effective manner. So the rationale for bone health optimization is very common in elective orthopedic surgery. Prevalence in adults over the age of 50 is somewhere between 10 and 30%. It's associated with complications of orthopedic surgery. Relative risk is 2.5 to 3, associated with poor outcomes and increased revision surgeries. So just to show I'm not a curmudgeon like the previous two speakers, and that I'm pretty hip and I can even use emojis in my talk, we don't really want to have patients go through this scenario. And the fact of the matter is you can mitigate this by proper pre-treatment and continuing treatment after surgery. This is a program that we started at the university with Neil and Kristen Hare for bone health optimization. And 124 patients were referred to our FLS program for preoperative consultation because the surgeon was concerned about the bone quality. We looked at images, we took a history, and we said, we think this is going to be bad bone. Maybe we should do something about it, get it fully evaluated. And when we looked at these 124 patients, indeed, they had very bad bone. In fact, these patients had worse bone than our hip and spine fracture population. The mean lowest T-score was minus 2.4. 56% of these patients had a history of a fracture since age 50. The FRAX threshold was exceeded for MOF in 82% of patients, and 92% of patients met NOF criteria for drug treatment. We treated them all with calcium and vitamin D. 45% received anabolics, 30% anti-resorptives, and some of the others either didn't qualify for treatment or flat out refused treatment. So one of the other things that most people don't consider is what we do in our orthopedic surgery may affect the bone downstream because we create a significant inflammatory state. And this leads to cytokine activation and activates osteoclasts, as Joe just talked about. And this will lead to regional bone loss and increased fracture risk. And here's just an example. This is a study Diane and I and Neil did where we were learning how to use DEXA to evaluate the femur around implants. This patient had a right total knee. The bluish purple thing is actually the knee replacement. But if you just step back and look at the left femur compared to the right femur, you see the right femur has significantly less bone, and in fact it did. This is a meta-analysis that we published of studies that documented bone loss along the femur after total knee arthroplasty. And you see a rapid loss of bone, and you end up being almost 20% bone loss on that femur that has never recovered after a uncomplicated total knee. Well, the same thing happens in the spine. This is a study out of Turkey where they did L2 to L4 pedicle screw instrumented fusion, and they did serial CT scans and using the Hounsfield units, which gives you an index of bone quality. In the instrumented segment, there was a 19% loss of bone in the L2 to L4 area. But even in the non-instrumented junctional level, this is the level above where the surgery stopped. So this one did not have surgery. There was a 16% loss, almost the same amount of bone loss in the adjacent segment on the spine as there is in the femur after total knee and total hip replacement. Well, what do surgeons think about this? Well, there's been a couple surveys where we asked surgeons, is the presence or absence of osteoporosis important in your clinical decision making? And surgeons, of course, say, oh, of course, we're totally concerned about that. And 77% say, yeah, that may affect how we're going to do the surgery. At the same time, how many people actually ever measure bone density? It was 5%. So there's a big dichotomy here for this. And that's one of the things we're trying to overcome. Well, how do you approach optimizing bone in spine or orthopedic surgery? Well, it's a programmatic approach. It needs to be comprehensive, based on risk stratification, should be easy to use, and evidence-based to whatever degree is possible. And this is really the same methods that surgeons use to optimize many other medical conditions before surgery. And the basic schema is that we look at a patient, we try to see, do they have a disease that we need to be worried about, such as diabetes or cardiac disease. If they do, then we do a test to see what the severity of that disease is, and then we may optimize if required. An example is diabetes, so we take a history, review the medical record. They have diabetes, we would check a hemoglobin A1C, and if that's out of order, then we would undergo optimization before we would consider an orthopedic procedure. Same thing for cardiac risk, we use METs. If they can't walk up 2 flights of stairs without getting short of breath, they see the cardiologist, get an echo, and then if that's positive, then they get optimized before we consider surgery. Well, the osteoporosis is going to work the same way. We, first of all, screen them to determine who needs a DEXA. And if they pass the screening test for DEXA, then we obtain a DEXA. And then we use the DEXA with the risk factors, determine whether they need to have treatment for their osteoporosis before surgery. So how do you identify those patients who need DEXA? This is challenging for orthopedic practices. We're seeing a lot of patients, and we're trying to sift through these patients. Well, ISCD last year published a position statements on which orthopedic patients should undergo DEXA scanning. I'll give you a rundown version on the next slide. But this was what we abstracted from that investigation, which is the UW screening protocol, where we look at females over the age of 65, males over the age of 70. If you have a history of a fragility fracture after the age of 50, doesn't matter where, except for fingers and toes. And if there's a high frax risk, and right now we're just determining who needs a DEXA, so the frax risk is done without a BMD of greater than 8.4%. If they meet any of those criteria, then they would get a DEXA scan before an elective surgery. And this only applies to patients over the age of 50, and the screening is done at the time we discuss surgery with the patient, usually the first or second visit. It could be applied to all patients who come in But right now, we're just concerned with the surgical ones. For those who use Epic, which is probably almost everybody in the state of Wisconsin, of course, I don't know if anybody's familiar with Health Decisions, but this can be placed in your Epic. It's uh, an add-on program by a company that helps you calculate the fracts. This is most of the information is blown in. You have to add a few clicks, and then you get your fracts risk assessment. Well, we evaluated this screening program of these 4 questions in 628 consecutive orthopedic patients. They had hip replacements, knee replacements, shoulder replacements, as well as spine surgery. The only criteria was over the age of 50. And we determined the sensitivity and specificity of this, and we classified patients, whether they're osteoporotic or not, using NOF criteria. The sensitivity of this to determine who needs DEXA. So right now we're just determining, do you need a DEXA, was 1.0. So we had no false negatives. So if they were positive on that questionnaire, got a DEXA, we identified every single patient with osteoporosis. And the specificity was 0.61 or 61%, which is still pretty good for a screening test. And this was true whether it was spine patient or total hip or joint arthroplasty patient. Spine patients actually did a little bit better. So it was a very simple protocol and identifies patients who need DEXA. I don't need to bore people here with how DEXA works, but that's going to be the gold standard for us. And as Neil said, I think everybody, particularly orthopedic surgeons, who are going to use this to do bone health optimization needs to become competent in reading this. Most surgeons are very competent at reading CTs, MRIs, ultrasounds, other things that they use, and they also need to get competent using this. Trabecular bone score might help us in some cases here to identify those with degraded microarchitecture, which may well correlate better with what happens after orthopedic surgery, although we don't know that for sure. BFA is always encouraged when I'm screening or when I'm ordering a DEXA scan, particularly if you're going to do spine surgery. It's kind of nice to know if there's any proximal fractures, because that significantly increases the likelihood we're going to see more of them after my surgery. The other thing that we use that can be used is opportunistic CT scan. So if there is a chest or abdominal CT or thoracic or lumbar spine, you can measure what's called the attenuation coefficient. It's a tool in the PAC system. You draw a circle and you get the mean Hounsfield unit. And a basic rule is if the Hounsfield unit is less than 110, then the bone is suspect and likely osteoporotic, and that would be an indication to obtain a DEXA and fully evaluate that. If the bone's over 150, then you probably have normal bone. And this is a strong prediction of complications with low HUs of a variety of complications. So once we've obtained the DEXA, we've made a clinical diagnosis of osteoporosis or not, then who do we send off for the bone health optimization? Well, again, it's using the NOF criteria. If they meet that, then they go see our FLS program. But other ones that I would advise patients, and these are my opinions, those patients with degraded bone score, low CT Hounsfield. I think if you're doing revision surgery and you have even osteopenia and the patient's had a bone-related complication, that you probably want to optimize the bone before you reoperate. And if you're doing high-risk surgery where we do like a 10-level fusion or an osteotomy to break the back or something, then I think those patients should undergo bone health optimization.
5 minutes.
What happens here? Well, this is done by in our case, by either Dr. Binkley or by our fracture liaison service, Kristen Hare. And you do the same exact process that you do for a fracture patient. You screen for secondary causes. We optimize vitamin D, recommend lifestyle changes, assess fall risk, nutrition, and medications. The fall risk is very interesting in that after knee and hip replacement, 30% of patients will sustain a fall in the first year. And that's one of the reasons we're seeing such an epidemic of what we call periprosthetic fractures. Vitamin D, of course, I won't go over this since Neil went over this very well. And unfortunately, since Schlitz beer took vitamin D out of their beer, we're now in Wisconsin, we're all vitamin D deficient. Uh, so what are our choices to treat this? Well, we can obviously use anti-resorptives or anabolics. And orthopedic surgeons really worry about the healing of bone from particularly the anti-resorptives. But all studies show that there's no or a slight positive effect on fracture healing or fusion from anti-resorptives. And anabolic, you can see rapid improvement in strength within 2 or 3 months. However, you don't see any really a positive effect on fracture healing from anabolics, surprisingly. What you do see, though, is lower revision surgery rates. So these are two large database studies of each over 50,000 patients, and they just looked at those receiving bisphosphonates and those who didn't, and looked at revision surgery, one for total hip arthroplasty, and it was a 50% reduction in revision surgery if you received a bisphosphonate. In spine fusions, there are 6 randomized controlled trials where they look at clinical results, time to fusion, fusion success, and hardware failure. And these all had varying outcomes and different results, but 4 of the 6 had at least a positive result in bisphosphonates with one of those domains. 2 studies had no difference between placebo. And these are relatively small studies, so a lot of them were significantly underpowered, but still showing positive results. The same thing for teriparatide. The other 2 anabolics have not been tested in the spine, but these all show positive either clinical results for fusion success or lower complication rates with the use of teriparatide. Bone health optimization will result or need for delay in surgery. And this, of course, gets patients very upset, but we've had good luck explaining to them why we're doing this. And how long you delay is really a matter of opinion right now. And I'll give you our opinion is that if you're doing kind of a small operation in an osteoporotic patient, like a total hip or total knee, then maybe consider 3 months of treatment. If you're doing bigger operations like a multi-level, couple level fusion or putting in screws, maybe wait 3 to 6 months. And if you're doing really large cases with known risks of secondary fractures, these would be multi-level fusions, revision knee or hip replacements, or a patient has severe osteoporosis by Neil's definition, then you may want to go 6 to 12 months delay. And again, our primary treatment in these patients has been to try to get them on an anabolic agent. So conclusion is that orthopedic surgeons, now FLS coordinators, and even bone health physicians need to recognize that orthopedics is a big problem for the orthopedic surgeon and their patients, and that someone needs to take ownership. Our model is the FLS, and that all patients undergoing elective orthopedic surgery over the age of 50 are screened to determine if DEXA is needed. They should all be given vitamin D and calcium. And if treatment is warranted, it should be given both before as well as obviously after treatment. And the best way to accomplish this is through some type of bone health service within orthopedics or in your local community. Thank you very much.
Thank you. We do have a question. Spine surgeons often want anabolic pre-op. If they can't take this, we advise bisphosphonates, which makes sense based on the data you showed. Yet many orthos are afraid of bisphosphonates pre-op. What should I tell them?
Well, they could call me or read some of my articles, but it's just that there's 6 randomized controlled trials that show no negative consequences of bisphosphonates. Plus, there's multiple systematic reviews, meta-analysis that show no ill effect of bisphosphonates or denosumab, for that matter, on spine fusion. So it's a matter of ignorance of the literature. So that's about all you can do.